Suppose, as Dr. Mathur alluded to, there's a lot of stuff that we could talk about, right? So I kind of thought the theme underlying today would just kind of just focus on retrogrades, because there's a lot of interest in India in retrogrades, but I think the skill set and the know-how is not necessarily across the board. So before I introduce the case, just want to, unfortunately, I don't have the diagnostic pictures because this is a live case, but I'm just going to show the case here. So we can still discuss about setup, guide, and everything else, but that's kind of what that's the case that was on. So before I actually get into anything, I would like to know, let's say Sanjog or Pratap, one of you guys want to take on and say, what do you guys use for guide in general? It's an RCA CTO. I mean, obviously, obvious.
Arun, would you give us some introduction of the patient? Any basics about what age, how much ejection fraction, and
EF is okay. Thank you very much for that. No, all I know is that EF is normal, creatinine's normal. The guy was like maybe in his 60s. Is from Hong Kong. Had been attempted before, failed, has pretty bad angina on good medical therapy.
Okay. So we'll go over to Sanjog. And Sanjog, how would you approach this case? And you've got a calcified CTO in the right coronary, and there's some disease in the LAD.
Yeah, so in general, I'm, where possible, a radial femoral guy. I try to do biradial when they're a little bit more straightforward. I try to avoid bifemoral when I can, because I think that nowadays there's just no need to take on the risk of 2 femoral accesses when one will do. 845 sheets for the leg. Usually use a 7 French guide through that so I can get my ACTs from around the guide. And then I'll use either a sheethless guide, 7 French from the wrist, or a 6-7 slender or merit sheath, and then track up a standard 7 French guide into the donor artery. I like bigger guides. I don't think that they cost too much, but it is important in that regard that you're careful about monitoring your contrast and how much you bleed back, because you do lose a lot more blood through those things. Insofar as the case itself goes, Arun, can you play the pictures one more time?
Yep. Just gonna do that for you, brother. Okay.
So from what I saw, very diffuse disease right throughout the major part of the RCA. The occluded segment itself, it cuts off sort of in the left picture, but you see that the occluded segment itself is probably over 20 millimeters, significantly calcified. It's almost completely osteal. You know, the question of whether or not epicardials or interventional collaterals depend largely on, you know, whether or not you're an experienced operator and are used to doing those types of retrograde wiring collaterals. But in general, this is a high, and it's been previously attempted. So this is a high JCTO CTO. It's JCTO4 at least. And the calcium is going to be your biggest problem. I think my starting approach to this guy would be much as Arun has chosen, where I'd either go bifemoral or I'd go femoral radial. My right arm guide would probably be in the left system because it's closer to me, and I'm going to end up likely doing most of my work here retrograde. I'd start something antegrade to serve as an antegrade marker, and if I get lucky, I'll go through, but given the amount of calcium that's there, I think that's probably unlikely. And then start going retrograde. My approach to retrograde after ballooning the LAD lesion to make sure that there's appropriate flow, but not stenting it until I'm on my way out, would be surfing those septals. I think it's worthwhile trying septal surfing on each of these types of cases long before you start going after epicardials, and then selectively injecting your large epicardials and picking which one is most appropriate.
Great points.
Comments from you, Pratap?
Basically,
just one quick thing. I do want to add to one thing. I mean, actually, I wanted to confirm rather, or agree with Sanjog on one thing. This guy had radial stuff before, and he had no pulse on the right. So, and I hate left radials. I mean, I agree, but this was a live case, and I was like, no, I'm just going to go bifemoral. And also, the other thing too, just to add on to what Sanjog was saying, you know, using the right radial for the left guy, I mean, just the way it sits, you do get a lot of backup, especially with the XPs and the EBUs.
Yeah.
When you engage the left coronary system. So that's one of the reasons. So I'm sorry, didn't mean to cut you guys off, but like Pratap, I'm sorry.
Atul, I will actually just take this case as a bifemoral approach only. As Sanjog told, I don't go for radial and femoral. My comfort level is bifemoral, and bifemoral I take some most of the time 7 French catheters on either side. Usually in a CTO RCA, I prefer to take an Amplatz catheter, but the left side is EBU. If the catheter is actually having an excellent backup is not required, then I take a JR catheter, especially when there is a real osteal disease. Number two, I'm not really understanding how the collaterals are there. I will take some more injections, even though the contrast usage after the projection will be very less. But initially, I will read very well the angiogram properly to understand how many collaterals are present. And I don't prefer an epicardial collateral. That will be my last choice to take. I will always try to take a septal collateral. That is for any beginner to do CTO intervention. I will tell that should be the choice. And when you are very well versed with the septal collaterals, then only you should try epicardial. Epicardial is actually looking very decorative, but that will cause real damage to the patient as well as catastrophe in the procedure. Number two, I could not say exactly what is the length of the CTO segment. Probably, as Sanjog told, you may feel that it is calcium, but really I am not understanding whether it is real calcium or some staining part there. I'm not sure about it. Maybe calcium, but you should have a long CTO, and I have no anchoring chances there with the angiogram available from the right side. But even then, this case, I may try with an antegrade first, and I may not be successful in antegrade, but I can have a preparation of the antegrade lesion, and so that my retrograde intervention will be much easier. These are my choices in the initial level, but I will look for some more angiogram shots.
Sure. Sahil,
a couple of,
when you have a look at the, yeah, I'll just come to you.
Can I add just okay.
Yes, sir. Yeah, Sanjog, please.
Sorry, I was just going to add that I completely agree with everything that Pratap just put out. I wanted to underscore the idea of epicardials not being the first choice. You know, we don't want to demonize good wireable collaterals, but at the same time, I mean, I was always taught until you've done 50 or 60 good septals on your own, you shouldn't even think about going after an epicardial collateral. And if you're going to do that, then you need to have all of the usual perforation kit, complication management kit in your lab ready to go with all of the equipment necessary so that you're not, you know, caught in trouble. I do agree with Pratap as well that I think, you know, that's what I was mentioning is the left-sided picture sort of cut off. So it's hard to tell how long the lesion is. And I don't think that there's ever a downside in getting going antegrade to be able to start the preparation of the vessel. The exception is when you have flush occlusions and osteal LADs coming off of the left main, where you risk either perforating or you risk dissecting into the only remaining vessel on the left system, in which case I'll get a retrograde wire up first, use it as a marker, and then go antegrade or use IVUS guided puncture or something along those lines.
Sanjog, I just told this because it's an academic program, so we should tell the points to any person who wanted to begin CTO intervention also. We should tell them the points. When there is somebody who is really experienced can go with any collaterals. I may go with an epicardial directly also, but I am telling that if that is a septal collateral, that should be the first choice to take, even if an epicardial.
We're totally in agreement
there.
We're all in agreement there.
Yep,
absolutely.
Yeah. So a quick question to Sahil. And Sahil, when you had a look at this angio, what are the points that you decide that you want to go antegrade or retrograde? What do you look for in these angiograms?
Yeah, so I think it's Sanjog and Pratap made really excellent points here. I mean, this is an extremely challenging case. It has been attempted before. Progress CTO, JCTO scores are very high. Now, a couple of questions before I answer that to Arun. Arun, what kind of workup do you do in these patients? How do you decide you're going to go after this? Because this is not one of those straightforward cases where you just walk into the lab and be like, hey, you know what? I'm going to open this CTO. I think there's a lot of workup, and then patients need to know, because the risk of complications when your progress CTO score goes up is almost hitting 5-6%. And that's one question. The second question is, what approach was done previously?
Great. I think that's a fantastic, really good question. And so, I mean, unfortunately in this particular patient, like I said, I mean, this was not an Indian, this was a case that I did last year in Hong Kong. And I didn't have the luxury of it. I mean, I pretty much knew that, hey, this is the case you're going to do. So I didn't have a lot of, workup stuff that I could do before. That's number one. Number two, but the key it was, I knew the people that were setting it up, indications were rock solid. He already said, hey, this guy has been tried before, really wants it done on max medical therapy. So I knew that indications were really good. Had not had a CT scan before, which I don't feel compelled about every time, but sometimes it's helpful. I mean, there's a question asked about, is there calcium, is there not? I mean, ambiguous scores, prior attempt failure by an expert. Sometimes having a CT is helpful. And the modality of failure last time was they actually managed to go retrograde, but they couldn't finish reverse card. So that was how it had failed last time. And it was actually done by a fairly experienced operator, or attempted by a fairly experienced operator before. So yeah, I mean, that was the modality of failure.
So one more question for discussion to Sanjog and Pratap. When you see patients who come back with, a retrograde attempt, do you usually look at those old pictures to see what vessel was attempted and whether it's still available or not? And especially when you're thinking about, using one of those juicy epicardials, which is just so scary. I mean, how do you decide that? Or does your approach change that, maybe they tried going antegrade, they switched in 5 minutes to retro thinking, it's not a good idea. Should I give it a shot antegrade? Not in this case, but in usual referrals you get.
Pratap?
Yeah, I mean, Pratap, do you want to start or do you want me?
Okay, Sanjog, I will answer and then you will go, because see, I will actually tell even any patient who is attempted by a retrograde first by some other operator, I usually try an antegrade approach, because that actually sometimes, they may not use the ideal wire. So most of the time you may take a very tough wire and just land up in problems. You may take an XTR and it crosses the lesions. Sometimes you will feel that you are successful, but many a time, if somebody attempt also, but you should give a try with an antegrade. That is actually a bottom line. Some of the case I went retrograde and I failed and go back to antegrade and finish in 5 minutes. And I was actually thinking that why I went retrograde. And this actually make you to think in retrospection. Actually, now I always give a try antegrade, even if somebody tries and fails. But as you told one important point, sometimes, when you do a retrograde attempt and you may damage some septal collateral, that is very, very important, because that collateral you preferably to avoid and learn and make a magnified projection of an areocranial and areocaudal to understand where the A angle and the B angle, the entry point and the exit point, to be looked very carefully in a septal collateral. That is very important, and that will be the cause of most of the failures, not only the CTO segment.
Sanjog?
So there was a bunch of questions in there that are sort of testing my memory, but I'll try my best. So regarding how you look at films from previous, generally when I'm taking on procedures from outside, I ask for all of the films, not just the last attempt, but as many films as I can get, because getting an idea of 50% of our cases are post-bypass, right? So the anatomy is all often very badly distorted. So having the films from before their bypass are particularly important so that you understand the structure of the vessel that you're trying to treat, what they're supposed to look like, if you will. And then understanding where the bypasses were put, how they were put, and how the anatomy may be tented is very important as well. It gives you a much better idea of where everything should be, and I think it gives you even more confidence to go antegrade, because you know where your vasculature should be, as opposed to guessing. As far as looking at the previous attempt goes, always we try to teach now that if you're going to fail with flair, right? Don't just fail. Modify the vessel. Do something different. And I think Pratap's point of coming antegrade on your second attempt is particularly important, because a lot of the time when you've done dissection in both directions, or you've ballooned, or you've tried card, or you've tried AFR, or these kinds of things, you've modified the vessel enough so that after 6 weeks of healing, you may have one or multiple channels that allow you to come antegrade with relatively soft wires, Fielder XTAs, Pilot 200s, these kinds of things, as opposed to getting really, really hardcore with some of the more directed penetration wires. My approach is a bit hybrid on the retrograde side, where I like to map out the collaterals that I'm going to use. So I do a lot of selective injections to try to define things. But I also recognize that selective injections are only worth so much, and that a lot of times the collaterals that are there that do connect, you can't see, particularly in the septum. And so I make sure I spend a good amount of time in the septum retrograde if I've made the decision to use that technique before I start thinking about selectively injecting epicardials and these kinds of things. And the last thing I have to say is we've written a retrograde paper out of OpenCTO that's currently being reviewed, and it's a registry, and these are faults of all registries, but it's an NCDR audited registry. And one of the things that we've noticed is that retrograde complications do appear to be connected to the difficulty of the case, but they are overall numerically higher, right? So I think the informed consent discussion with patients is extremely important, where you've got to not only have the literature data available, but your data available, right? You need to know what the MACE rate is in your hands and in your institution with how many cases you've done year on year. And then you need to advise patients of that, so that on your first attempt in a case like this, maybe, yeah, you'll go retrograde through the septals, you'll try antegrade. If you fail, you'll do spam or subintimal plaque modification, and then leave with the understanding that if the patient is local and you can bring them back in 6 weeks and you need to use an epicardial to get retrograde, then, in 6 weeks on your second attempt, that's what you'll do. That's different than a patient who's flown halfway across the country to come and see you, because in there, you're a little bit more invested in trying to get the job done for that patient's benefit.
So Arun, would you show us some more pictures to see how the collaterals are, and so maybe we can have some more comments?
Wish I could, but I can't. So, I mean, I don't know if it's projecting very well through Zoom, but actually,
it is very clear.
They're very usable septals. At least that's what I thought. And I don't. Can you guys see the marker, like the pointer?
Yeah, we can see your marker.
So yeah, I mean, I kind of thought that's not too challenging. I thought it connected. So I was just gonna go and start wiring that, see if it connects, and if not, if I have a problem, then I'll deal with it. And my whole thing was, okay, last time they failed because of the calcium. That is what in my mind I was like, okay, this is what I got to deal with. And I completely agree with Pratap. Like, I mean, the key to this was, and by the way, yeah, so all that stuff that you see there, that stuff that I'm pointing out at the arrow, that was calcium. So it failed because of calcium issues. So, and it's always good to start antegrade. I completely concur. There are a few exceptions to that rule when you absolutely, you have a blunt stump, et cetera, true osteal lesion. But in most cases, yes, I do start antegrade, because even if you are going to go retrograde, you're getting the job done. Antegrade, you're doing the prep. And as Sanjog also mentioned, this is a fairly longish lesion. So I would need antegrade prep anyways. It's not going to be a retrograde true to true. Very unlikely, right? So anyways, that was kind of my process anyways on seeing the initial setup shots. So I'm just going to...
What was the hardware that you had decided, Arun? What hardware did you plan to use?
I'll get to that in just 1 minute. So I kind of, this is for the beginners kind of thing. Like fundamentally, when it starts with retrograde, I would just say I don't have too many slides that talk about theory, but this is just one thing that I feel like people need to understand this. So the basic concepts are these three, right? You want to go beyond the blockage and get some kind of control over that, right? And for that, you need some collateral. You need a septal, epicardial, or a bypass graft. Bypass grafts and septals typically being way safer than epicardials. And then you want to cross the CTO and you want to connect the antegrade and the retrograde stuff. Hold on, give me 1 second. I don't know what's going on. Okay, give me 1 second. Okay, and then you want to cross the CTO segment itself after you get some antegrade purchase. And then essentially you do this either through a true wire, true to true, or you go reverse cart, or you do a classic cart, which we don't do that much anymore. And then you want to finish up your PCI. So these are really the steps, guys. Give me 1 second. I don't know why these lines just popped up. I'm going to close this.
That's the Zoom thing. It's not your presentation. It's the Zoom thing. It's coming on the Zoom screen. Maybe the host can help us in this. Yeah.
Okay, that's all right. As long as you guys can still see. So what we knew about this case was it's kind of longish. I know I have a clear cap. It has been attempted before. Reason it failed was because of calcification. Distal caps at a bifurcation. So my plan really was, do the antegrade work, but plan is to start doing reverse card. And if that fails, try a high-end ADR. And getting to Dr. Mathur's question, I mean, so in each of these segments, you use different strategies, right? Like, so what is the toolkit that you need for each one of these? So, I mean, number one, I think everyone kind of mentioned this. This is a case where you need great backup. So an AMPLATS is way preferable. That's the first thing that I would say. Don't start off with a JR guide. It's actually asking for failure. And I didn't try too hard to wire it. That's an XT that I just decided, okay, I'm going to knuckle this up front. So here's where I actually wanted to stop and actually ask specifically Pratap, would you try, I mean, I think I did try wiring it, and but how long would you try to wire this anti-grade, and what would you do?
Actually, that is a very important question, but I just wanted to tell Arun, I have to look at the distal cap where there is a bifurcation. There is an ambiguous distal cap or not. That means the distal cap is actually at the branch of the PD and PLV, or you have some segment away from PD and PLV. If there is a small segment away from the PD and PLV, your chance of success through retrograde is much higher. Otherwise, your chance by retrograde as well as antigrade is a question mark here. So that is actually the key point there. I could not, that is what I was looking for. That's a branch or the bifurcation branch, PD and PLV. How many millimeters away from the PD and PLV, the CTO segments ends, that I could not see. But I definitely don't do a knuckle. And knuckle is actually the last choice I prefer, but I just wanted to tell knuckling is a choice by many people, but usually I avoid knuckling in CTO intervention. I just get a fear of getting a lot of subintimal, but even many times Arun told that knuckling will not create that much subintimal path, but I still have a fear of knuckling.
And this is exactly what I think Dr. Mathur was talking about, like, you know, the Japanese school of thought.
Very interesting. So, very interesting.
To each his own. So, no, just to kind of get to the non-controversial point, the distal cap was truly at a bifurcation. So, you know, so that was, so I had no room. And in fact, for the hybrid guys, we are always thankful if it's not at the bifurcation, because that makes our ADR so much simpler. If it's at the bifurcation, yes, it's still possible, but it's really not my first choice. I would much rather prefer to go retrograde if it's truly at the bifurcation. I just wanted to say that. Sanjog, would you knuckle, not knuckle? What would you do?
So I don't know if you can see me squirming when he said I don't like to knuckle, because this is in fact the difference between you know, the Japanese school of thought and the way we do things here. I had to knuckle this. I would have taken a Mongo antigrade. I would have slipped it through as far as it would go. I would have knuckled it as soon as it would knuckle, and I would have knuckled it into a safe place into the mid vessel, put on my catheter down, put it on suction. If I had a landing zone, I would have tried ADR. If I didn't, I would have gone going retrograde. Okay. I agree with all of the comments about the distal cap ambiguity. I think it's important to be careful where you stop your knuckles. If you're going to knuckle, which I think is an invaluable technique in CTO PCI, you can't do it efficiently without that tool. Then make sure you have very careful distal landing zone management. You can't just let your knuckles float anywhere you're going to float, because then your subintimal space will grow. And this is where things like trap liners or guide liners can help by plugging in the inflow into the subintimal space, so that you can prevent your subintimal space from expanding with blood, and you know, and allow yourself the time that you need to get retrograde or to get to your second segment of therapy.
So if there is no distal cap,
let's take another view. If
you have a distal segment is not there, also you try to do knuckling.
So I'm not sure I understand what you mean. If I don't know where the
your segment of CTO starts, actually there is no PDA PLV, that junction, the CTO ends, then you have no space, you know.
No, but that's basic, right? You don't knuckle past the bifurcation. That's the point that I'm making. Okay. But that's why you need the retrograde approach. Is you need to make a subintimal plane in order to be able to do reverse card. The most difficult way of reentry is from true lumen retrograde into false lumen antegrade, right? So you have to be able to get into the true part of the bifurcation, but that's where I'm going with landing zone management, right? There's, to me, trying to knuckle or trying to wire through a cobblestone street full of calcium is painful when I can just knuckle past it and then stop the knuckle proximal to the distal cap, come retrograde, come through the distal cap, make a knuckle in the retrograde space or retrograde subintimal space, do a reverse card and get the case done.
Okay, you're not allowed to tell what I was going to do.
Wait, Arun, let's take another opinion. We've got Kirti Punamia who's joined us. So Kirti, your opinion on knuckling. Hi, welcome.
Hey. So My apologies for being a little late, but I've been hearing all these comments.
We accept the apology.
I know, thank you. I know, it's been
right?
getting a habit, right? So, yeah, so I haven't seen the retrograde fill the distal RCA, so that's my little limitation to this commenting on this one.
Arun will show it to you.
Yeah.
Knuckling is his point.
Yeah. So would you use a knuckle or not?
Oh, so there is that little stump there. So you have a, when you, I know what Arun thinks more, and again, it's a philosophy, and I would struggle a little more with the wire. Arun would feel a little hesitant to do that and probably start doing a knuckle all the way earlier on into the case, establish an access into the distal RCA retrogradely. And am I seeing the distal RCA or am I seeing just PDA-PL?
There's not much PDA. I mean, there's not much distal RCA to be seen.
But there is
my question would be to the both of you, Arun and Sanjog. So we will knuckle, and we knuckle, say, to the distal RCA. Where do we stop when you really don't have a cuff to go ahead and re-enter? Or are you going to come back thinking of an ambiguous cap and enter into an area which you're not sure of? Because is it possible that you could not be anywhere close to a distal cap and still poke into a normal artery?
Yeah, so you get into difficult scenarios here because this is obviously a very difficult case, right?
Right.
The point was made earlier that you don't knuckle past the distal cap, otherwise you start chopping up normal vessel, and you try to avoid knuckling past bifurcation because you want to maintain integrity of all of the end distal branches, right? And on my screen, I don't know if it's our internet, the films are a little bit choppy, so I really don't have a good sense of the distal RCA and what it looks like. But in general, wherever you end up coming retrograde, you breach your distal cap as close to a true lumen segment of vessel as you can, and you accept that that's going to be that's going to be a reconstitution point. Once you're done reverse carting, you connect point A to point B. If you have the difficult scenario of separate occlusions in the PDA and RPL, which is I think what we're getting at here, right? How do you manage a difficult distal cap where you have both vessels potentially compromised? Those are challenging scenarios, and there's a couple of ways to solve that. One way is doing the retrograde, picking one of the kids and going on if the other one is really small. That's not my preferred. One way is coming retrograde and then doing a second retrograde loop to pick up the other branch, taking both retrograde wires up and then flipping it antegrade. So you just do a simple standard bifurcation PCI distally. And then the third way is to come retrograde, reconstruct from, let's say PDA all the way into the mid RCA, and then using retrograde injections from the retrograde limb, you do an antegrade dissection into the second branch and you do a re-entry there. And then you back up and you complete a culotte or a reverse culotte. That allows you to get both of those branches. But these are uniquely challenging issues for very difficult cases. They're not the typical case.
So if I hear you correctly, if the distal cap is ambiguous and it is right flush to the bifurcation of the distal RCA into the PDA-PL without really a good visualization of an entry point retrogradely, then you would not hesitate to see if you could knuckle way past that little area and try to make a re-entry into one of the major branches and then work backwards.
No. That's not what I'm saying. That's the opposite of what I'm saying.
Okay.
What I'm saying is you knuckle only in the body of the RCA,
right,
and then you use your retrograde wire to breach the distal cap, and then your retrograde knuckle starts in the body of the RCA as well.
Oh, okay.
Right?
Okay.
You do not compromise. You don't compromise your distal vasculature. You don't compromise the distal bifurcation. The difficult scenario is when you have separate occlusions into both major branches of the distal right. So if your PDA is separately occluded and your RPL is separately occluded, and both occlusions lead up into the main RCA. Then you have two distal caps.
That doesn't seem to be the case in your case.
No, that's not the case.
No, it's not the case.
But he's just talking about the
point that I was
situation. Yep. Right on.
Okay, Arun. So let's see. How did you go forward?
So trying to get more antegrade purchase. That you see a guide extension catheter and trying to get balloons down, and that was a microcatheter. I just couldn't get any gear down beyond that particular point that you see the mid RCA, just kind of kicking it out. So
it is a fine cross, microcatheter fine cross, right?
I think I tried both. A Corsair Pro, which was, or a Corsair, I don't remember what we had at that time, and a fine cross. Neither would go.
Do you have a rotational
I had a very low profile balloon.
Like
I tried to do granuloplasty and then get something down. So the usual algorithm for wire across, can get gear across, kind of went through that fairly fast. But I think I did do rupture 2 balloons too, which I don't know. I mean, Pratap would probably kind of say again, don't do it. But I mean, it actually works pretty well.
We can definitely do that. Granuloplasty can be done. There is no problem.
So we have consensus on something. Good.
Yeah. No. I wanted to ask Arun because which microcatheter use, because these type of lesions, if you take a caravel, it will be a dangerous situation. The only catheters can be. I wanted to stress to the point because the participants.
This is a very good point.
Here,
that's a great point. Yeah.
This is a very good point.
Either a fine cross or maximum a Corsair Pro. And I personally feel fine cross will be a much better choice in this case.
Great point.
Do you have Turnpike LPs?
Turnpike?
No, it's not available in India.
Not yet in India. No.
Yeah. So that's So Corsair Pro XS, some sort of rotational low-profile microcatheter or rotational microcatheter is much preferred to a caravel because you'll leave the tip behind.
Yeah.
If you end up getting stuck in this kind of calcium with a caravel, and it's worthless for support.
Sanjog, tonus, how is it? Tonus can work in this case.
To tell you the truth, I have limited experience with.
No,
tonus.
you can't.
We don't use it here.
But Kirti maybe knowing.
We don't use it.
No, you can't use tonus in this at all.
It's pretty big, right? Tortoises are large. It's very hard to kind of move your way.
Knuckled wire can be used. Kirti, not possible, right?
So tonus is in 2.1 French and 2.7 French, 6 French, and either one, you cannot use it for this technique. The whole thing will just unwrap. Yeah.
I completely agree with Kirti because one of the key things is like, I mean, it's going to kick everything out. And frankly, I think there's also an availability issue these days with tonus. I don't remember the last time. It's been more than 2 years since I've touched one.
No, it's available. I mean, in my lab, it's on the shelf all the time.
You have it.
But it is very less available. It's not easily available now.
So now we know who's holding it.
No.
So okay, at this point, by the way, guys, for those that don't know, Kirti is one of the stalwarts. Not to say others aren't in rotablation too. So I would love to. So in fact, what I did was I kind of was going through this fairly fast, and then I had the additional pressure of being on camera. So I just decided I'm going to drill it. Mm-hmm. So do's and don'ts. Hear what the panel has to say about it. Would people, how many of you guys would even consider it? How many wouldn't? So as you can see, I already pulled out the wire because I kind of went through this, didn't work. So I was going to throw in a rotor wire and drill it.
It's a great option according to me, but you got to limit it to just that space and those millimeters that you think is the calcium obstruction, and don't go beyond it because the rotor wire, whether it is luminal, subluminal, or it doesn't matter as long as you are just carving out a little groove for yourself in that proximal calcium to enable instrumentation of that artery antegradally. That's about it. I wouldn't run it beyond 5 millimeters or 6.
Is the laser catheter available there?
Nope.
Is Elka? Okay, that would have been a good option here as well. Did you try antegrade Carlino?
I didn't Carlino here. I did granuloplasty.
Right. So granuloplasty helps. Sometimes I will Carlino, and that'll soften up the tissue in multiple different places. Or you can Carlino even as you pull the microcatheter back.
Completely agree.
But I don't have a problem drilling this. If you have to drill it, you have to drill it. But I agree with Kirti, and then you just have to be careful. Don't go too far, and avoid drilling too far in the subintimal space because they hate that.
Sanjog, I have a question. Just to interrupt. We don't have laser. We're going to get it soon. But my question over here is when you don't know what space you are in and when it works so much with just contact, is there a small chance that you could actually perforate this artery prematurely, especially if you're not in the vascular space by any chance?
Well, you shouldn't be taking, I mean, you shouldn't be taking gear forward unless you know that you're in the vessel architecture, right? That's the bottom line, right? So unless you're absolutely certain you're in the vessel architecture, you can't do that. I mean, you do multiple views. You can do a dancing view, for example, where if you've got a wire down and you know, your microcatheter is where it is, you can do sweep views to make sure that the vessel is dancing with the wire. You can potentially even put, if you can fit a small balloon in, you can, you know, do aspirations on the microcatheter to see if you're getting blood back, these kinds of things. You can at worst hook up a microcatheter to a pressure transducer to see whether or not you're getting pressure transduction through the mid-vessel, though in the subintimal space, sometimes that doesn't work.
So in the subintimal space, when you're doing excimer laser, you're quite comfortable using excimer.
Yeah, so the answer is you have to be very careful, but you keep your fluency and your rate low, avoid contrast, and all you're doing is lasering the point at which the microcatheter won't move forward. So you laser that very small area, then you take the laser out and you try to make your microcatheter fast. So that's an important part of the algorithm for the gear, for the wire across gear won't go or impenetrable proximal cap.
So Keerthi, if I may, I've used a fair bit of laser both in the coronary space and in the peripheral space. I mean, I think the point that Sanjog says, and the one that you made about rota, right? Just do it for that segment that you really need to. It's really not so much for the subintimal space, but for that proximal cap or whatever that you can't break, that's really, you're just trying to change the morphology. And more aggressive measures are like laser on contrast, yada, yada, yada. You could, but I mean, I think for beginner level safety laser stuff, it's really about that point where you can't get across.
Right.
And then
once you're in the
subintimal space, it's a lot better.
Arun, you could cross the rota wire easily here.
Yeah, so I pulled out the mic. I kind of, while you guys were talking. So yeah, so basically what happened was, I was able to get a wire down and then drill it across. So what I did was got my, I think it was here, right? Okay, yeah. I got my microcatheter as far as it would go, because till that point I was making progress, right? So I just got it right over that bend, and then I just pulled that wire out. The rotor wire went fairly, I think it's towards the end of this run that I just pulled it out. I think that's as far as I got with the with the microcatheter. And the rotor wire went fairly easy. The rotor itself was not too hard to be, I mean, like, you know, it was a 1.5 laser. Oh, that's the other thing I do want to say is I've never done more than a 1.5 rota in the subintimal space, and I don't think it's generally a great idea to do it. I don't know, and there's no reason to do it really, because you're just trying to modify something.
There's no need to.
Yep. And here, actually, you guys can see that the microcatheter, I mean, this is the beauty of, I think, rota when you do it right. I mean, it just kind of sailed right through. I don't know if this is the same run. Oh yeah, it is the same run. Okay. There, I mean, it just literally slid right past. And the rest of it was actually fairly straightforward. This was kind of the fun part of the case. So then again, I kind of got a knuckle, had it seat there. So now all the antegrade work was done. And the key, again, I think has been mentioned multiple times, is don't let the knuckle advance beyond the bifurcation.
Right.
So once this is done, the rest of it was, I was able to get a guide extension catheter. I did all my antegrade work up front in order to minimize my retrograde gear time. So there, now I got a balloon down. I'm able to advance it. I'm sorry, let me just, okay, so then let me just let this whole thing play. So now you got a knuckle, which is fairly safe. It's somewhere in the architecture of the vessel, I think subintimal, so anchor balloon, get the guide extension catheter down. And now, now you're ready to go retrograde. So the next step really is just to cross it. I think this was just a Corsair and probably a Cyan, don't remember. Yeah, it was Cyan. So this part wasn't too challenging. And this was the septal that I think I showed initially. So this was kind of the easy part of the case. And there you see that there is a PDA there. And I did take a deep injection here because it wasn't super clear. I mean, I guess we were kind of talking about where is the distal cap. That's where the distal cap is. And I might have had more projections. I just don't have it on the talk here. Sorry. So typically, again, ideally, an LAO cranial would have been great for this. So the rest of it really was, I think, as Sanjay kind of let the cat out of the bag. But it really tells you this is what most of us do. I mean, you kind of go into the plan. penetrate, knuckle retrograde, and then essentially work. I mean, you've done the antegrade work for, guide extension reverse card, and that's really what we wanted to do. So at this point, we confirmed that I penetrated with a CP12, just got a knuckle going, and now I got antegrade and retrograde knuckles.
Nice.
So, I mean, now you're in the game. So, this is a much more controlled event at this point. As you can see, my guide extension catheter is knee deep into the RCA. So I don't remember, actually. I think I probably used a Gaia third for doing again, I'm just going to show a minute. For those people that are still wondering what a reverse cart is, essentially, you cross antegrade. I mean, there are multiple ways to do it, but in essence, what you're doing is this bottom part that I'm just pointing to. You have a balloon antegrade balloon it, and then use a retrograde, traditionally a stiff wire that's fairly torqueable, get into the same space that the antegrade balloon has created. Why is it called reverse cart and not cart? Because originally cart was what was done. They took a balloon retrograde and used an antegrade wire to get into that space. And since that came first, that became cart, and then the subsequent thing is reverse cart. So, and guide extension reverse cart is pretty much what I do for the most part in cases, much more controlled, simplifies it. You don't have to necessarily shorten the guide. There are lots of advantages, gives you a better target, and kind of obviates the need for doing, the whole thing with stent extension the stent reverse cart, etc., which I don't think I've done one in a very long time again. So essentially, this is the retrograde wire getting into the antegrade, or maybe it didn't, whatever. So there you see essentially now that you ballooned it, you take a retrograde wire, pull the balloon back, take a retrograde wire, and get into the guide extension catheter. And I'm going to skip this part since we are kind of running short of time. And then the rest is just PCI, really. Now you have an externalized wire. And so once you have the retrograde microcatheter is in the antegrade guide extension, take out the penetrative wire, put in an RG3. We don't have R350, so it's just RG3 in Asia for the most part. And then you have a grade rail. I mean, you got a wire going in through the antegrade, come out through the retrograde. You kind of have a really nice, kind of a cardiac floss, and do the balloon, optimize the whole thing with imaging. Again, we got imaging experts on here. So anyways, the key is make sure you do a good job of stenting. I think initially we were a little bit maybe cavalier about it. And then this is kind of the post-stent result. And I'm just going to let you see this in this projection once more. And I mean, the fun thing was, being efficient really from when I started from this picture to end, it took that's 14:30. I mean, 11:35. The timestamp here is 14:06. 2.5 hours, we were done. So, I mean, the whole idea of knuckling and doing these things and keeping things moving is that you can move fairly efficiently. And you don't have to spend 8 hours in the cath lab trying to get this vessel open.
That's very impressive, Arun, being able to do this in 2 hours and 31 minutes, particularly as part of a live case. Pratap, I'm sure you'll agree that this was a very challenging case. I think the underline has to be put into here, though, that you are an expert operator. And the expectation should neither be to take on this case early on in someone's training, nor to pull out a rotoblader until they have lots of experience doing these types of cases. And that the expectation of efficiency, safety, comes before quickness. I don't know that many people anywhere that could do this case in 2.5 hours. So congratulations, it's very difficult.
Thanks,
so the rotablation could not have been done after you had done the retrograde access, because you could not have done the reverse cart. Your balloon was not going forward. Is that right?
So I had to, I mean, the whole idea of doing the rota thing was to prep the antegrade bed. Because, regardless of what I bring retrograde, and plus it'll also shorten the time for me, in terms of how long am I going to be retrograde. And the other thing, India is actually pretty good about ACTs. There are many labs where I started doing a lot more tip-ins, because there are many labs, and especially when I was proctoring a lot in China, where ACT was completely unreliable or just unavailable. and with the language barrier, etc. And sometimes you just be like, hey, can I have an ACT? And then like, there is no ACT. And then you're freaking out because you already have gear down and whatever. And, you know, you thought you heard something, and then you got to really either switch the system to antegrade, or because I mean, especially during training and, you know, in the US times, we were so anal, like 30 minutes, I want ACTs. And India is actually pretty good about that. But there are parts of the world where we don't. And I think having the longer your retrograde gear sits, the higher the chance of complication. I mean, Sanjog might be able to tell me from registry, but, you know, in general, I think that's a decent rule of thumb.
I think
the lack of an ACT to me is terrifying.
That's a terrific case. And as Sanjog said, this is not a simple case. And it's awesome. I think your strategy of cracking that calcium proximally with a rotational atherectomy was great. And did you, by any chance, did you do an image on this at all? Did you guide your image, or did you not
for the
particular case?
We did do an IVUS run. I kind of don't know if I just kind of skip through the guide. I mean, I unfortunately do not have the IVUS run, Kirti.
That's okay.
But we did, you know, we really, because, you know, we wanted to really understand how the, you know, the distal cap was, how far to stent, etc.
Yes.
So we did do it, but I unfortunately don't have those runs. I apologize.
So
no, you don't.
Kirti and Sahil,
yeah.
When do you look at imaging in a CTO case? You know, Sahil and Kirti, you know, if you want to take up this issue.
No, I think imaging in any complex case is a prerequisite. I you know, that's sort of what we've been doing for a very long time. I think especially where I train and where I work, I think imaging is very important. The other thing is these patients, it's, you know, what Arun has done is an exceptional case. And like Sanjog said, not many people he knows or I know would be able to accomplish this. Now, this is a part of the whole spectrum. These patients have very high risk of ISR. They have very high risk of stent thrombosis. I mean, they need to be followed up. They need to be managed appropriately. And I think imaging is so important. You don't want to get all this way, do so much work, even if it's 2 hours, 31 minutes, and then lose your patient to either under expansion or, you know, you're trying to, that's my honest opinion. I think once you've reached here, it's a full, complete picture. Is not just finishing the case, it's what happens in a year, what happens in a couple of years.
That's a fantastic point. And I think, you know, in fact, honestly, I think the hybrid operators in particular, like, you know, are, you know, in fact, I still remember the words, like once you externalize the wire, it'll be like, all right, 15 minutes, you got to be out. But I mean, that was our working rule. And I think over the last couple of years, I think we have all been more meticulous about imaging and making sure it's not just winning the game right now, but like it's the long-term results. And I couldn't agree with you more. It's about optimizing your PCI results. And now again, you know, I think the question was really about imaging in CTO PCI. For the most part, for the stent optimization, I mean, dealer's choice, use whatever you want, OCT or IVUS. But I think for a lot more other things, like, you know, identifying the cap and this and that, I think IVUS is a lot more useful in general. But again, you know, I think it is critical that we not just stent and get out, but we actually do a decent job of stenting so that the patient is benefited over the long term.
Kirti, how often do you pull out imaging catheter? Yeah.
If I
100%.
100%, there's no question. I would not complete a case without imaging, and I would have to have a very good reason not to image, really, and partly being.
It is a wonderful case. Actually, I would have done a little different in these cases. One, I definitely will not do a rota in this case. I will never do a knuckling in this case. And I will try to do maximum retrograde because I have a segment of nearly 2-3 millimeters for the crossing from the PDA to entry there. And if that is not, that is an ambiguous one, I will be in trouble. I think it is a wonderfully done case.
I think Pratap, exactly. I mean, and Arun made this point, if I can butt in here just to kind of say, you know, the few fears that we have and the fears that we kind of consolidate our practice on and build it so hard and try not to jump over that and cross the other side is that we don't want to knuckle and we don't want to pull out a rotablator to crack the proximal cap. How do you complete it then? You won't get your microcatheters down. You won't have a small area to kind of get your two knuckles together and then cross over. I think what Arun has demonstrated is how to just make a very difficult case simple by using principles very solidly, and then completing the case with image guidance. Because Sahil actually mentioned very clearly that you need to optimally size, but those people, I see a lot of overexpanded stents in CTOs, and you go and injure the intima, the media. You actually tear the media sometimes, and that does you have a very large lumen, but counterproductive. Those don't stay open at all. They actually come back quite nastily. So just getting the right size of the stent is perfect. I mean, you don't size it as well as just as you don't want to undersize it.
Let me just add one thing to what Kirti said. That's actually a great advantage that you have in India, to be honest. So in the US, unfortunately, let's say once you're done with the case, right? Unless there's a big clinical reason or a clinically indicated, you can't just bring them back for a routine angiogram. I mean, it's kind of hard because insurance not going to take care of it.
Absolutely.
But for a lot of our patients, we have the luxury of saying, hey, this is enough. You don't want to tear the vessel, especially the distal place where it might be like chronically negatively remodeled. And you have the luxury of saying, okay, I'm going to bring you back after a while and then really optimize it later. I mean, those are all things that I think are actually really good in India, especially when you have a good patient-doctor relationship.
I'm not sure if really that is good, because we end up doing a lot of, I think we need to have a definite guideline as to why we need to get patients in, and they should be ischemia driven alone, not just to take a peek at 6 months or 7 months. And therefore, actually, I am not happy about us being so liberally allowed to do what we want to do. In fact, we should have restrictions, in my opinion.
Honestly, I cannot take that leap out of your book, because for some of the patients, don't you bring them back and do a follow check angio, etc. So I kind of thought, hey, that's something I can do in India, maybe potentially, just to, because sometimes you end up undersizing stuff, etc. Say you
not
don't
for
have
not for CTOs. I would.
Yeah,
do that
CTO
for
PCI
mains.
I think is a special case there.
Not for CTOs, but I would do that for left mains. Bifurcation left mains, I would do that, because there is a small room to do a repeat angiogram in absence of, because we found significant TLRs which could be corrected even before they had symptoms, just because we did it at that time frame. And some of them can get very nasty if you leave them alone for a while.
Interesting.
Excellent. If any more comments on this case? Otherwise, Arun has a very short case.
I got a short
awesome.
case.
That was awesome, actually, Arun.
Yeah, this was good. So let's see your second short case.
I've got to jump off. My apologies, but
Sanjog,
thank you
so much.
Sanjog, thank you so much.
Great
thank you very much,
Look
Sanjog.
forward to seeing
Appreciate it.
Bye, Sanjog.
Take care, everybody. Thank you, my friends. Bye-bye.
Thank you. Bye-bye.
Bye-bye. Thank you.
So
okay, quickly, another 5 minutes.
Escorts, actually. So again, the patients, and there's actually Dr. Mathur, you might remember the clinical history better than me, but let me see.
Yeah, this patient's son is a cardiac surgeon. He's working in Middle East, and his father used to be living in UP somewhere. Is this the same patient?
Yep.
Okay, yeah, that's right. He's a post-CABG patient and refractory angina. RCA was CTO and failed antegrade approach once. Is that right?
Yep.
Okay.
And again, this really illustrates the point where you have two discrete CTOs. I mean, and I think that's one of the things. And so this again was a case where you have a longish proximal to mid RCA CTO, as well as possibly a PDA that's total. So I guess I have Sahil, Kirti, and Pratap to pick on now. So any takers?
Yeah, Sahil and Pratap, please.
Yeah, basically there is a PDA occlusion is there, as well as the I will actually, even now, this you can try with an antegrade first.
Antegrade.
No doubt about it.
I would try antegrade here.
Okay.
Kirti?
Obviously, Kirti.
Antegrade. Kirti is not there?
Kirti is muted.
Okay. So
you have very good collaterals to serve.
Yeah.
Yep.
So
no, you got great
spend 15
brother.
minutes on antegrade. That's it.
Yeah, I think a short antegrade, see if you get somewhere, and otherwise I think come retrogradely for this, yes.
Yeah, so again, given that, the thing is, like, I didn't really want to lose the PDA. It was a true, kind of a flush PDA occlusion from the antegrade segment. So, I mean, given that I really wanted to get the PD, went retro. So that's where you are. And I was kind of hopeful there might be a microchannel here, but as you can see, not really, right? So if you come antegrade here, right? I mean, and this is just a challenge, right? And yes, you could probably come antegrade and possibly wire till the mid RCA. What's your strategy? I mean, you could then say, well, I'm going to use IVUS guided imaging, identify where the PDA takes off, and again, you're going to try and wire it. I mean, these are fairly longish lesions. I think the probability is fairly low of success.
No. Actually, Arun, we have to do a antegrade wiring. Take the wire into the PLV. Take a cruise site. Try with an antegrade to the PDA. That's what usually I do. If I'm not successful, I take a retrograde wire and go to that, and then there is a wire antegrade to the PLV and retrograde via this. Then we can take procedures finished. That is the way.
No, a great point. I mean,
but I have
two caveats. You got to get true lumen into the RCA, and number two, you got to identify the proximal cap as to where the PDA takes off. So I'm sorry, Keith, you were saying something.
It is very easy to say that we should identify the proximal cap using intravascular ultrasound. But when you have an artery as diseased as this in the distal RCA, amidst the plaque that you see in the distal artery, in the native artery, it would be difficult for a lot of eyes to actually pick up that proximal cap correctly sometimes. And believe you me, with a 40 or a 45 megahertz IVUS as well, this is not going to be easy to locate the cap, in my opinion, because there is a lot of plaque there.
Okay, good. Anyways, I'm trying to wire it, and I'm in no man's land here. I'm not really sure where the wire is going.
But this is a soft wire, right? Is that a soft wire? Or what wire is this?
I honestly don't remember.
It doesn't look like one of those fielders. It looks like either a UB3
it might be a Gaia or
it's a Gaia. It looks like a Gaia.
I think it's a Gaia.
It's a Gaia, yeah.
Yeah.
It's tapered Gaia, yeah.
It's either Gaia second, third, or Conquest. Don't remember.
It's not Conquest.
You're almost making me think it's an early takeoff.
But the key was I wasn't sure about where I was, right? I mean, I think really the point that I was trying to make is that you could be, and I mean, obviously before I escalated wires, and I'm not showing you every run, right? I mean, we kind of go through, hey, let me probe with a hydrophilic polymer jacketed wire. Let me try with an XT. You kind of go through the thing. And again, in India is a land of limited resources. And many times, again, maybe not for a patient whose son is a cardiac surgeon, but many times we got to be cost conscious. So, but we did go through like safety first. You want to try a polymer jacketed wire because they tend not to exit the vessel's architecture. But then, again, the key is don't move the gear. I think Sanjog, who's not here, made the point. Like, if you don't know where the wire tip is, don't move gear.
Don't move the gear, yeah.
So anyways, given time, so ended up knuckling. Sorry, guys. But again, I knew at least I was in the vessel architecture. And interestingly, it really it was really, as Keithy rightly predicted, super early takeoff PDA. Not where you'd think it would meet like this, but really kind of just went down. And partly I'm showing these cases because, I mean, I think it's about having different schools of thought. And so as you can see, I got a knuckle up all the way.
I want to stop you there for a minute.
Sure.
How wide a loop would you accept for these retrogrades? I mean, how wide a loop is a good loop? Or how narrow would you
I was going to ask that question.
I mean, because I just thought that this is a very wide loop. So I'm, Arun, in your hands and another hand, I mean, there are probably 100 people watching this. How wide is a loop that you want?
So there are 2 or 3 determining factors of what is this. I mean, assuming you're in the architecture of the vessel, all right? So if a knuckle explodes, it doesn't matter what it is, it's never a good thing. It means you're kind of perfed already, all right? So different wire, any wire can be knuckled. And the size of a knuckle is a characteristic of two things. One is what's the size of the vessel. If you're in the subintimal space, a bigger vessel tends to form bigger knuckles. Number two is the property of the wire itself. Now, an XT tends to form a much tighter knuckle than a Mongo, than a Pilot 200, than a Gaia, than a Conquest Pro 12. So, I mean, like I said, you can knuckle anything, but you need to understand what is a good knuckle. And I think that's a great question, because if you don't know that, then you're in trouble, because sometimes knuckles can be unwieldy. And in general, what is this acceptable knuckle? It's that knuckle that you need to make to get the job done, because sometimes an XT will not be able to give you enough penetration force to get across, and you might have to kind of upscale to a Pilot or to even a Gaia. So, it really depends on what is the job that you are trying to get done.
Yeah, actually, Arun, without a knuckle also your wire was going like this, You actually had a fear that you are out of the lumen, right?
You are right. I tried for a while and I just wasn't sure. So I just felt like from a safety standpoint, Pratap, you're right. I mean, maybe I was in there. And when I took pictures, retrograde, I was nowhere close to where I thought I should be. So,
maybe a CT angio would have helped
standpoint, absolutely, I think a CT would have been really, really useful. Yeah. And if I had failed this time, that's probably what I would have done. And the second point is, it's also a safety thing, right? I know a knuckle is much less likely to exit the vessel architecture than a penetrative wire. And so here, once again, it's the same team. I got a microcatheter anti-grade. And I'm really close. I mean, now I'm dancing. I'm in the same space. And the rest of it is just like the last time. And it's just you get an anti-grade wire, knuckle, balloon, retrograde wire to just get into the same space. Actually, I think my retrograde microcatheter just popped in. I didn't even use a wire for that. And then externalize. That's the RG3 going. And so the one thing, right, and I was mentally prepared for this, was, what happens to the PL, right? Because I was subintimal all the way from here, and I got lucky here. So, and this is not ballooning, I didn't wire it, whatever. But I was prepared to take a dual lumen catheter because I have good access, and I had an epicardial, which would not have been my first choice. But what I would have done is to go back anti-grade, put in a dual lumen catheter, and then penetrate into the PL. And then if I need to do a reentry, so be it. But that was kind of my game plan. Had I lost access, I had good flow, and I'm like, okay, I'm just going to let this heal. And with the last time, the son is still friends with me on WhatsApp. So anyways, the last that I checked, I think his dad was doing pretty well, and Dr. Mathur might be able to give me a more updated version. So he's not.
So he's history of symptoms for the last 2 years now. Yeah.
Good.
But you did, when you look at this last picture, there is something at the PL branches in it.
Exactly. No, because
go back and try to correct that, or did you just leave it?
I left it because, I got TIMI3 flow. I was just going to let the dissection heal. If I do get back in, and I know for a fact that this region, right, the stent here is actually subintimal, but for whatever reason, I have antegrade good flow. And many times you think when you have a knuckle that you are definitely committed to being, that you are subintimal, or rather, not in the plaque. But, sometimes it surprises you. As you can see, had I truly been completely subintimal, I wouldn't have had all these RV branches. So again, I think it's just kind of an interesting case, because it makes you think, like, many times when you knuckle, you're not, you're not necessarily subintimal. And the other thing that gave me confidence to an extent was when I got my antegrade gear down, they were literally, and this part I knew was, initially at least, was true lumen. They were like so close, and I'm like, this is a good chance that maybe I am true lumen for more than I thought I would be. So I was just going to take it as a victory and run, not try to chase it.
Arun, unless you have actually ruptured or disrupted many layers of that artery, how do you expect a wire which is coming in retrograde subintimally and preserve a branch through its path? Because I would think that just an automatic as an inference would be that the external elastic lamina from the opposite end goes and sits across the lumen thereby occluding it. So the fact that you have flow in there, either you've disrupted that, so there is a fenestration through it, and therefore, or you are truly within the plaque body, and therefore you may have started somewhere, but it looks like you're actually within the plaque and within the intimal space at that junction.
And Kirti, that's what actually surprises. I mean, you're completely, I think, logically correct and on money. And in fact, that was our initial thought process. Like many of the times when we were doing CTOs, is like wiring. We are always true. I mean, generally, right? And then when you're knuckling, you are pretty much, it's given that you're not going to be in the true lumen and you're always subintimal.
So I ask you this question again. Did you image it?
No, not in this
before
case.
you stented it.
No.
Not in this case.
Come
Actually,
on.
I will ask you, Arun, one question. Arun, one question back to you. Because you told the PLV is coming in the distal part, you are not sure that the entry of the PLV and the PDA, the junction was much ahead. But I'm seeing the PDA PLV junction is much lower here. How is it happening?
What do you mean it's low?
The junction and the PD and PLV. You just
But
see
this is a different view, Pratap.
It's a little different view.
Yeah, so we originally were thinking that the PDA, just imagine the PDA, draw a straight line from the course of that distal PDA. Distal RC. That's where we were thinking. And when this wire deviated, that's what I thought. It's actually pointing to an early takeoff.
Right.
I think that's where the smart Arun did this job, and he made a knuckle there and try to be within the vascular space, because wires could lead you outside and more likely than a knuckle. That's what, am I right, Arun?
I mean, I think that's really kind of the teaching point I want to make. And yes, you're right. I don't remember exactly why we didn't image, but we didn't. And I think the other kind of the point I wanted to clarify was there are times, and in fact, the UK guys actually published this stuff and said, like, there are many times when wiring ends up being subintimal, and it actually goes true, falls true. And you're pleasantly surprised that when you do knuckle, there are many times when you are true lumen. I think in one of my talks, I actually have that, the numbers, but I think up to a third of the time you are, you are actually where you're true lumen even when you knuckle.
I think so.
So there's a question from the audience. How many times, Arun, did you have a perforation with your knuckling?
Actually, perforations with knuckles are extremely rare. Typically, the time you perf is you've already perfed with the penetrative wire, and inadvertently you've taken your microcatheter across, and then your knuckle explodes. So again, going back to this, knuckles generally don't cause perfs, and I personally, if I had to attribute it to a knuckle, I would say almost never. Now, there is another way you could. When you're trying to star and when you knuckle, which I think most Indian operators anyway don't do it, is if you don't realize that you've gone way past and you keep pushing it really hard, you could have an end wire perf. But you got to obviously know how to star, and I think there is some learning curve to knuckling too. So it's not just boom, I'm going to start knuckling.
Yeah, actually, I will ask
Arun, I have a question.
Okay, so we'll take some take-home messages from each one of you. So Sahil, first from you.
Atul, one question. Atul, one question.
Okay, Pratap,
Arun, actually, if you knuckle and if you not re-enter the vessel in the true lumen, then what will happen?
I'm sorry?
If you are knuckling in the subintimal space and then you are not able to enter to the true lumen, then what will happen?
Re-entry.
You're talking about an antegrade knuckle or a retrograde knuckle? When you're doing ADR or when you're doing retrograde?
Even antegrade. You are doing a knuckling, you are not able to enter the true lumen. What will happen?
ADR.
So that's okay. So when you go antegrade with a knuckle, the idea is to be able to controllably re-enter, which is ADR, antegrade dissection reentry. Now, does it work every time? No. So what your question is, what happens when ADR fails and there is no retrograde option, right?
Yeah.
Okay, so that's when I think most of the hybrid guys, we tend to do, okay, we're going to fail, let's fail at style. Is there something that I can do at this point in order to improve my chances of success next time around? That's the whole concept of spam, or like subintimal plaque modification, where there are times where you either, star, if there's just a single vessel, balloon the whole thing, walk away, don't stent, bring them back 6 to 8 weeks later, and then reassess it, because, you might be pleasantly surprised. And I think the numbers are close to 70% of the time where it ends up being, you actually have a wireable lesion at that point.
Okay.
Sorry, I think the take-home messages, guys. Does anyone want to?
I think
yeah. So yeah, go ahead, Kirti. Please go ahead.
So I think, sorry, Sahil, but I think Arun, you
Kirti.
demonstrated amazingly how I think our threshold to knuckling has to change. It can't be high. We can't be resistive to it. It's not damaging. It's more controlled, and it's probably more going to lead us in fruition most of the time if we know what we're doing. I think I also learned, and I think you mentioned it, and I've learned it from some of your talks earlier, as well as my chats with you, that one needs to be able to control the loop on that. And the way you control the loop is, one, the artery will control it for you, but I think by choice of wire. So if you want a smaller loop, it is better to take a softer wire, and the harder and the more stiffer the wire, or the stronger the wire you take, the larger the loop. It's just the law of physics. And sometimes you just got to be smart when you're kind of making a choice of your wire. I think the third thing that that is interesting, and we've talked about it a few times, and I think it's come up very well in this first case of yours, Arun, was to modify the cap at least at the proximal end. In fact, only at the proximal end. Sometimes, even if it is subintimal, I think a rotational atherectomy 1.5 burr can do a great job as long as you limit your rota just to the cap, and then use that to kind of advance your devices down to kind of complete and get a contact point. But I think, and I take home from this that once you have established a connection, then you must image to kind of complete the case, because that's where we learn sometimes whether we are overzealous and overstretching the artery, or we are too defensive and under expanding an artery. And I think both are not going to do as good. Over to you, Sahil, to add, to change your thoughts on this.
No, I agree. I was actually going to ask Arun, but I think we are beyond time now. I think for most of the people to understand that your decision for knuckling is not just based on an algorithm, it is also based on what your lesion is and what wire you're going to use. So you cannot have a broad knuckle in all lesion subsets, and what approach you have, whether it's an ADR sort of approach or whether you're as an adjunct to your retro case. So it's two different things. The most important thing in all these CTO PCIs is you have to have the right indication why you're doing it. They're all fraught with complications. Arun probably has seen a lot in his life. Pratap has, and Kirti has. And we look at these cases and we're like, you know what, I'm going to do this tomorrow in my cath lab. I think that's not the right approach. So you have to have the right indication. You have to spend 15, 20 minutes looking at those angiograms, trying to figure out what your best strategy is going to be. You have to image at the end of your successful case. Investment is very important. If you fail successfully, if you will, and you have to have that approach for investment procedures. And knuckling is you need to know your wires, you need to know the lesion. Not if P200 is not going to knuckle all your lesions, is not appropriate for all your lesions. And I think that's sort of my take-home message.
Awesome, sir.
Yeah.
I think my take-home message is actually, as Atul Mathur told the first statement, how Pratap will approach and Arun will approach in a CTO differently. Still, I have a lot of reservations on the knuckling, but I think as Kirti told, we should not have that much threshold for doing knuckling in a minimum in a bailout situation, or a chance of failure is more than we should have. Second point I learned today is actually the rota. As Kirti told yesterday also, we had a discussion about the same thing in subintimal space. If you have a calcium is obstructing your wire to flow down, then there is still a chance of doing a rota, not only at the site where there is a calcium is obstructing, not beyond. These are the two major lessons we learned today, I think.
Well, gentlemen, thank you so much, Kirti, Sahil, Pratap, and of course, Arun. Mother, you have really generated a discussion where I didn't even need to do any moderation. And you had such intense discussion going on, and I'm coming out as a winner. And I'm sure everybody who's listening has learned so much. Arun, you've done really very challenging cases. And after hearing them out completely, we realized that how complex it has been. Even when I was watching you do this case, I really didn't learn so much. Now, today is the opportunity to learn these. So thank you all of you for taking out this time, because this is precious time. You'd like to be back with your family. And we would look forward to engage with you more in future. Kirti is going to say a closing remark on this.
It's not a remark. It's to my friend Arun. Okay, and I have heard Arun speak on CTOs plenty of times, and it is awesome that he takes 25 cases and wraps it up in 15 minutes. And I have always been the one guy who said that those 25 cases can be a talk of a 1 hour each. And that's what you need to do. And I tell you, today I am seeing that happen here. And it is so amazing, because this one case over 1 hour has probably taught more people so many things about what is packed in that big brain of Arun Kalyansundaram. And I think this was just an amazing demonstration of the detail that he computes. And we don't even understand it while he's computing and thinking 5 steps ahead. And this was just awesome how he has just plainly put 1 or 2 cases for us to understand. And this was an awesome presentation. The best I've ever heard from Arun, really.
Oh, wow. Okay. Hey, thank you for
big hand for all of you. Huh?
Thanks, Pratap. Thanks, Sahil. And by the way, Kirti, just to know, I listen to you all the time. That's how I do.
I think it goes without saying, Kirti is one of the best orators I've ever heard. So
no. Actually, from all of you guys. Thank you so much.
Everybody would like
Thanks,
give
guys.
That. Yeah.
Awesome.
Bye-bye. Good night.
That was just awesome. It was the best CTO session I've attended. Thank you.
Thank you so much, Kirti. Thank you. Bye-bye. Thank you very much.
Bye.
Take care.
Bye.